Welcome to our webinar today. My name is Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's event. Before I introduce our moderator, Kimberly Kelly, with our speaker Nicole Kupchik, I'd like to show our audience how to send questions and comments. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the GoToWebinar control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. You can also download a copy of today's presentation in the handout section of the GoToWebinar control panel. Our moderator for today is Kimberly Kelly. Ms. Kelly is currently a clinical consultant for Cheetah Medical and has been a critical care nurse for almost 15 years. She has been a very active member of the American Association of Critical Care Nurses and is currently a regional board member. In 2015, Ms. Kelly wrote a widely used self-learning module for use in her hospital facility on Code Blue. Kimberly, welcome.
Thank you. Good morning or good afternoon for some of you. Thank you, Tracy, for that very kind introduction. The title of today's webinar is The ABCs and CABs of Resuscitation. Are we causing harm with assisted breathing and ventilation techniques? Speaking today on this very timely topic is a colleague and friend of mine, Nicole Kupchik. Nicole has practiced as a critical care nurse for over 20 years, and about 15 years ago, she began working at Harborview Medical Center in Seattle, Washington. This was a change that spurred an interest in resuscitation in Nicole. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole founded Nicole Kupchik Consulting and Education. She has the following disclosures. She's on the Speakers Bureau for Stryker and La Jolla Pharmaceuticals, and she is a consultant for Stryker and Baxter Healthcare. Continuing education for nurses and respiratory therapists. This educational activity is approved for 1 contact hour. A link to obtain the CE credits will be available at the conclusion of the webinar. The accreditation statements are as below, and support for this educational activity has been provided by Stryker. Nicole, are you ready to get started?
I am. Hello, everyone. So welcome to everyone who's joining the webinar, and welcome back to some of you who've been on this series of webinars. So this has been a series for the past year and a half, just focusing on different areas in resuscitation. And so this session's a little bit different. So we're going to talk about the ABCs and CABs of resuscitation. Are we causing harm with assisted ventilation and breathing? Possibly. So let's just chat about that. So learning objectives for this session include that we're going to discuss the current recommendations. I'm not going to go into great detail about the recommendations, but we'll talk about the recommendations regarding assisted ventilations during resuscitation. We're going to describe recent hospital and EMS research regarding placement of advanced airways. And this has been quite enlightening. And then we're going to talk about the integration of capnography just as a way, I'm not going to talk so much how to use it as a marker of CPR and when to kind of terminate efforts or when you have rust, but more around how you can use it specifically for ventilation. So in resuscitation, if we kind of think about if I'm leading a program, or let's say I'm a bedside nurse, or I'm an EMT or medic, out in the field, what matters? And so if we kind of look at the guidelines, we know that chest compressions matter. They absolutely matter. And in fact, depth has the highest recommendation from AHA as a class 1 to hit a 2 to 2.4 inch depth. The rate should be no more, so 100 to 120. We should minimize perishock pauses. The ventilation rate for an assisted airway is recommended at 10 breaths per minute. Or if you don't have an advanced airway, you can do 30 to 2, so 30 compressions with 2 ventilations. I'm sure you're all familiar with that. And then we should be utilizing capnography for sure to verify endotracheal tube placement. And this is a must. This is an absolute must. But we can also use it for CPR quality, I will say with some caution, and then to identify return of spontaneous circulation. And then finally, medications. Epinephrine is recommended at 1 milligram every 3 to 5 minutes. And then for shockable rhythms, we can implement amiodarone, or you can actually use lidocaine as well. So, I'm sure a lot of you remember in 2010, we made the switch from everything being ABC, so everything was ABCs, to CABs, where we put more focus on compressions, airway, and then breathing. So why was this flip made from ABCs to CABs? And, and I think one of the thoughts is that in sudden cardiac arrest, you don't immediately deplete your oxygen stores, and circulation is paramount. If the patient is not getting compressions, they're not going to get perfusion to their brain, their heart, and end organs. And so, really putting a focus back on the compression piece of things. And I will tell you, just being involved in resuscitation programs for a really long time, is that first few minutes, especially in hospital codes, there can be massive delays in getting compression started. And so, again, just putting the focus on circulation as a major priority in resuscitation. Then a lot of you are familiar, a few years ago, the American Heart Association kind of came up with this idea of hands-only CPR. So for the community and lay people, they can do compressions and not do ventilations. And some of you may have heard my story on the last webinar. So the last webinar I gave, I had just a couple weeks prior had done CPR on a woman at the airport. And I will tell you, just to kind of recap what happened. So I was at the airport waiting for Uber and heard this, this, is there a doctor in here? I'm like, actually, there's a nurse. Here we come. I'm joking about that. But anyway, so we do CPR. It was me and two other women do CPR on this woman. And we did not do ventilations. We just did pure CPR. When the AED came, we shocked the patient, did another 2 minutes of compressions, and she regained her pulse after 10-minute effort. So pretty cool thing. And then after about 2 minutes after I left, apparently I had talked to the medics a couple days later, and she woke up completely. And so, what's the problem with ventilations? I mean, the problem, part of it could be just that we're interrupting and taking so much time to interrupt compressions. But the other thing is that there's this massive stigma. And I'll tell you, being in the airport, and I was in Seattle, so Seattle, we've got the highest probability of getting bystander CPR. And I asked, does anyone else out there know CPR? And no one came forward. And I think, it's scary for me, because I even stood there for a minute saying, I think she's, resting. I'm not really sure, and you doubt yourself. So can you imagine if you were a layperson, how scary this would be? But also the stigma on mouth to mouth. I mean, no one wants to put their mouth on someone else's mouth. And so, I think it was a really smart thing for AHA and the International Liaison Committee on Resuscitation to kind of have this option of hands-only CPR. Now, the thing is if you get training on CPR, you can't get, obviously healthcare providers need to learn the ventilation piece. You can't get a healthcare BLS card on hands-only CPR training. You have to do the proper CPR training where they do teach ventilations. But I don't know, I just think this was such a great movement by the American Heart Association. And just nationally, just so we're super clear, national bystander CPR rates are less than 50%. In Seattle, it's a bit higher. So in Seattle, it's more like 65 to 70%. But that's pretty low when you think about, across the country, your chances of getting bystander CPR. Now, one of the major things, and I saw this that night that we resuscitated that woman at the airport, is I think we need to start teaching people about gasping respirations. And this is just a study that was published about a year and a half ago demonstrating when patients go into a shockable rhythm like VFib or VTAC, that's pulseless, when they go into shockable rhythms, if they have those gasping respirations. And I'll tell you, it's really tricky, because this woman that we did CPR on, she was literally like, her chest was heaving. She had these gasping respirations from her sudden cardiac arrest, and she was in a shockable rhythm. And so when patients have those gasping respirations, their survival is much higher than when they don't have those gasping respirations. So you can see the red bars here demonstrate gasping before or during CPR, where the blue bars demonstrate no gasping before or during CPR, and big survival difference seen in shockable rhythms. Then you also see that in In non-shockable rhythms at all, there is, almost like a sixfold, not that sixfold is a big deal, is a huge difference here, but a big increase in survival when patients have those gasping respirations. But it can be super tricky because I remember somebody like yelling at me, "She's breathing! Don't do CPR." I'm like, "No, this is not good breathing." And so anyway, I really do think this needs to be part of training in BLS classes. But in general, our goals of ventilation are we I hypothetically, these are our goals: to maintain ventilation, to aid in removal of carbon dioxide, to protect the lungs. And so one of the things I'm going to talk about here in just the next few minutes is the idea of overventilation. And so we need to make sure we are not, see this big, huge bag here, this big, gigantic bag. We need to make sure we are not blasting patients' lungs with the volume from those bags. And if you look at the AHA recommendations, they say about a half a bag squeeze is all you need. And so you can see here in this picture, this demonstrates you could very easily overventilate someone in a resuscitation. I'm going to talk about the detriments of overventilation by using too much volume. But the breath itself should be 1 second in duration. So it's a quick poof, right? So it's a poof, and that's it. And sometimes in codes, you see people like just kind of like, really like compressing that bag for a prolonged period of time. And the problem is that introduces a lot of air into the patient's stomach, and then they can vomit. So that's a major, major, major deal. But where we have evidence lacking is, what is the optimal tidal volume? The answer is we don't know. We honestly don't know what the optimal tidal volume is. What's the optimal ventilation rate? Again, we don't know. We know fast is bad. We know fast is absolutely bad. But one of the questions we're asking is, do we even need a ventilation rate at all, right? Because I'll show you what some EMS systems are doing. And then what's the optimal amount of inspired oxygen? Because there was a study published last fall called the IOTA trial, where they basically queried the liberal versus conservative oxygen using the SpO2 as a marker, and found that when patients in hospitals had SpO2s of 96% or greater on supplemental oxygen, they had higher mortality. And so what is the optimal inspired oxygen during a code? We don't know, but we do know that hyperoxemia post-arrest is bad, and we know hypoxemia post-arrest is bad. So what is the optimal intra-arrest? We just don't know, but hyperoxemia probably is not the way to go, as is hypoxia. So anyway, so I know you're probably thinking, oh, lots of great answers here, but the answer is truly just we don't know. So ventilation strategies during resuscitation. So the current recommendations say 30 to 2 if you don't have an advanced airway, or if you have an advanced airway, 10 breaths per minute. Tidal volume enough to see chest rise. The only thing I can do is laugh about this, right? I mean, let's give me a break. We're in a code. You can't tell if you've got chest rise or not, but they say about 500 cc tidal volume. And now the thing I have to say about that is, like, that depends, right? I'm 5'2". 500 cc tidal volume is probably too much for someone like me. Whereas if I'm 6'2", maybe that's adequate, or maybe that's not enough. So, I think you have to just take into consideration, just don't overventilate patients' lungs. All right, let's talk about airway options during arrest. So very commonly, we can use a bag valve mask with a ventilation bag. So that's very commonly done in resuscitation events, both pre-hospital and hospital. So that's one option. Another option is we can place a subglottic airway. So that would be like the iGel, King Airway. There are a few different options there. And then finally, the third option is to actually intubate a patient during resuscitation. And the only thing I'm going to say about this, well, actually, I'm going to say a lot about this, but it's very challenging to intubate somebody during cardiac arrest. And I'm actually going to show you from a couple of different studies success rates of ventilation, of intubation using an endotracheal tube. But those are our three main options during arrest. Now, pre-hospital, there's been some interesting publications on using passive oxygenation with an oral pharyngeal airway. So the whole idea is you would put in an oral pharyngeal airway and just administer blow by oxygen with that. And it's very interesting. So what the protocol that I've seen, I believe the state of Arizona is a big user of this, but they delay advanced airway placement until about 600 compressions are administered, or about at the 5 to 6 minute mark. And they do this in witnessed arrest and shockable rhythms, and they've actually seen some really good outcomes from this. So, I think in a lot of different EMS agencies and hospitals are kind of looking at their data and saying, what else can we do? We know hyperventilation and overventilation is so detrimental to patients. And I really love that a lot of these agencies are pushing the bar and just pushing it and saying, actually, just passive oxygen suffice to these patients in the first few minutes, because we don't completely deplete oxygen stores. So let's focus on circulation, getting compressions started in these patients, see if we can get them out of their shockable rhythm. Because that's the thing. Like, so the lady we worked on in the airport, we worked on her for 10 minutes and she never got an advanced airway, and she didn't need one. And she completely woke up afterwards. So, maybe there isn't in the first, 5+ minutes, you don't need advanced airways, especially if circulation is going to be compromised. All right, so why is endotracheal tube placement been considered the gold standard? I mean, that's a question I've always hand read, but I think one of the main things is it allows for direct lung ventilation, so that's kind of a major plus. It protects the airway, so that's another major plus. You don't get as much gastric insufflation and air into the stomach, and then it protects against aspiration. So those are all major pluses. But is there evidence that many patients in cardiac arrest regurgitate before intervention? So this was a study that was published way back in 2007, where they were able to demonstrate that most patients actually, if they aspirate, do it before an advanced airway is placed. So maybe there's not a whole lot we can do, about the whole, about patients regurgitating, which is kind of an interesting thing. And then the second study that was published in 2016 demonstrates that you have to do over 50 intubations to maintain endotracheal tube insertion success rates of over 90%. And think about that. How many EMS, like medics, or let's say nurse practitioners or physicians, maybe respiratory therapists, how many actually get to practice this volume? Now, if you're a CRNA or an anesthesiologist, no problem. You're doing this every day, all day, right? But truly think about that. And this is over 50 intubations to have a 90% success rate in placing that endotracheal tube. That's a high volume. And you really have to question, are people getting these volumes, to maintain their competency and success rates in endotracheal tube placement? And, this is even with video assisted endotracheal tube placement. So kind of a crazy thing. So what are the main three potential problems with breathing during resuscitation? So I think the main things that always stick out to me is hyperventilation. So we bag way too fast on patients. And I'm actually going to show you guys some cases where that demonstrating we just ventilate way too fast. We overventilate, meaning that we give too much volume, and that can lead to some major detrimental effects. I mean, think about it. We naturally breathe on negative pressure. And then when we have a patient who we're resuscitating, we reverse this, and this can have major negative effects, where when air is being basically pushed into the airways and not pulled into the airways as we do naturally. It has a major effect on the heart. But and then finally, the last thing is positive pressure ventilation. And this is very easy to do, especially if you've got an advanced airway placed. And so these are the three major complications and problems with breathing during resuscitations. So again, just to recap, the recommendations are, if you don't have an advanced airway, 30 to 2, and you have to stop compressions for ventilations. If the patient has an advanced airway, 10 breaths a minute. And I will tell you though, a lot of systems, EMS and hospital systems, have kind of gotten away from this 30 to 2, and they just go to asynchronous breaths, so one breath every 6 seconds or 10 breaths a minute, regardless if they have an advanced airway or not. And so the advantage of that is you don't need to stop compressions for ventilations. So again, the problem being we give too many breaths and we give very large tidal volumes. So this is a patient who was intubated. So that this was a cardiac arrest, and they were intubated, had an advanced airway placed before the arrest, actually. And what you can see in this case, so this is a CPR report card, and these little red dashes indicate a chest compression. Where you don't see red dashes, that's where they stop compressions. And then where you see the little blue triangles, those all indicate a breath. And you can see in this case, there was major problems with overventilation. So 29, 35, 30, 27, 21. I mean, just really just massive issues with overventilation. And then here's another case I'm going to show you guys. And again, remember the red dashes are chest compressions. The blue triangles are assisted ventilations. And you can see here 41, 45, 49. Now, both of these cases were done with endotracheal tubes. So you know, if airway is done perfectly, so let's say we get the airway placed perfectly, in both of these cases, the patient's already had an airway placed, are we causing harm with the assisted breathing? And that is one of the major concerns we've got with these patients. And you know, anytime you increase the rate, the ventilation rate, this is going to have negative effects of positive pressure ventilation in the chest, which can lead to decreased cardiac output. It can lead to stacking breaths where they get kind of a breath on a breath, increased minute ventilation. So if you can imagine you're bagging somebody 45 a minute, this is insane, right? But it happens all the time. I'll tell you, this is actually not uncommon. But you have a lot of minute ventilation moving, which can cause hypocapnia, which can lead to, you know, cerebral vasoconstriction, which can lead to increased ICP. And you have lots of major issues that are detrimental, not only to the heart, but also to the brain. And so this is super low hanging fruit, right? This is stuff where we can just say, slow it down. So one of the exercises I always do with people is anytime I do a live seminar is I always have people hold up 2 fingers with an opposable thumb. And I'm giving you this idea as something you can do with your staff or people you work with, just as an idea for training. So what I do is have people hold up 2 fingers with an opposable thumb. And I said, okay, I'll say, let's pretend like we're bagging. So all of you out there, hold up 2 fingers with an opposable thumb. And then what I'm going to do is I'm going to count it out. I've got a stopwatch in front of me. I'm actually going to count out the breaths. And when I say breath, you give a quick breath, right? So it's over 1 second. So it's just a quick breath. Okay, so y'all ready? So here we go. So I'm going to count it out. So when I say breath, you go, all right, here we go. And breath. Now I'm going to count out 6 seconds. Note how painful this is. Ready? And that was a breath. Now we're going to wait another 6 seconds. Shouldn't be bagging. Breath. Another 6 seconds. We're going to wait it out and breath. Another 6 seconds and breath. This is painful. It's absolutely painful. But this is what needs to happen during resuscitations to minimize harm that we are causing with breathing. And we truly can cause harm with breathing. So we're going to talk about, the next thing I'm going to talk about are the physiologic effects, you know, when we overventilate. So let's imagine, okay, we had that case before where they were breathing. Let's go to the first case where they were breathing in the 20s, right? So if I'm overventilating during code, because remember the recommended rate is 10. So it's 1 breath every 6 seconds. So if I'm overventilating during a code, what's going to happen? Well, the first thing that's going to happen is you're going to increase the intrathoracic chest pressure because I've got a lot of volume going into that chest. I can be stacking breaths, of giving positive pressure ventilation. So your intrathoracic chest pressure is going to increase. All of that pressure can compress the inferior vena cava. So all that pressure can compress the IVC, which is going to decrease venous return. Then that's going to lead to increased pulmonary vascular resistance, which is going to lead to decreased cardiac output, which is going to lead to decreased coronary perfusion pressure. And all of this is going to have a major negative impact on CPR quality, a major negative impact on CPR quality. So other possible long-term effects, overventilation. So again, too fast, too much volume can lead to air into the stomach. It can lead to vomiting, aspiration, lung trauma. So we can actually induce an inflammatory response from overventilation. Patients can end up on mechanical ventilation longer. They end up with ARDS. They can get pneumos. And in fact, Nick Johnson, who's from Harborview in Seattle, very recently just published a paper on patients post-resuscitation. And ARDS is not uncommon in this patient population. So if you look at the Berlin criteria, for ARDS, these patients often have ARDS. And so can we minimize, especially lung injury by, again, not giving too much volume and really sticking to that rate, that slower rate? Okay, so let's talk a little bit more. And then I guess one other thought I just wanted to say is that, overventilation, we know from animal data that overventilation induces an inflammatory response, which can then lead to ARDS. So that, again, that's one of our major physiologic concerns that we have in patients with airways during ventilation. Okay, so let's talk about airways. Let's kind of dig in and talk about them. So Tracy, we're going to launch a poll because I want to know what people are doing out there. Okay, so you ready to launch the poll, Tracy?
Certainly. You can see it
Okay.
now.
Okay, awesome. So I want everyone to vote. And what I want to know is, how does your facility generally, so in general, I know not every case is 100%, but in general, how does your facility manage airways during resuscitation? So this can be your EMS agency, your hospital, your clinic, wherever you work. How does your facility or EMS agency manage the airway during resuscitation? So I'd love for you to vote. So Tracy, are the votes rolling in?
The votes are rolling in. Let's give
Cool.
everyone just a few more seconds.
I'm excited to see what people say. I want to know what's happening out there. All right, votes are rolling in. Okay, Tracy, how much more time are we giving them?
I think we're good. I'll just share the
Okay.
results.
All right, let's see what they said. Okay, so about 65% of you are placing an endotracheal tube. Oh, so very few subglottic tubes. So interesting. And then bag valve mask. Yeah, so BVMs are very commonly used, and sometimes we'll use them like with an oral pharyngeal airway if the patient's comatose. Obviously, they usually are in cardiac arrest. So okay, cool. All right, love this. Absolutely love this. So I'm going to keep going here. We'll get back to the presentation. So I love that, to see like what's happening out there with everyone. But okay, so this was a recently published study I wanted to go over. So the advantages of placing an airway obviously are for airway protection during a code, but do we ruin things with ventilation? But this study is taking an even different look and asking the question, how should EMS manage airways? So tracheal tube, so what they did was they compared tracheal intubation with either an endotracheal tube, as you see on the right, or a laryngeal airway. Now in this study, so this was done pre-hospital, and in this study, if facilities or agencies were using video guided assistance to place the airways, they could continue to do so. So again, we're comparing endotracheal tube versus laryngeal airways in the pre-hospital setting. And this was called the PART trial, which stands for Pragmatic Airway Resuscitation Trial. This was an NIH-funded study. They evaluated over 3,000 out-of-hospital cardiac arrest patients needing airway placement. So 27 different EMS agencies participated, and this is a randomized crossover study. So what they did was they'd say, okay, this EMS agency, you place laryngeal airways for 3 to 5 months, and then the next 3 to 5 months, we're going to cross over, and then you're going to place endotracheal tubes. So does that make sense? And they would do a crossover for periods of time. So that's kind of how the setup. And the first interesting thing I want to show you, so you guys might be wondering, who is that guy up there in that picture? So that's actually Mohammed Daya. So he's Dr. Modia, amazing EMS leader out of Portland, Oregon. And so he and Henry Wang out of Houston were the two PIs on the study. So the first thing I want to show you is, now remember, this is pre-hospital. And all I have to say to any medic or EMT who's on this call, my hat's off to you, because what you do is, your work environment is so challenging. I mean, if you guys could see, like nurses, we have such a controlled environment, right? But I mean, they literally show up to somebody's home or a public place and have to resuscitate patients. But airway placement success rates. So check this out. 90% success rate with a laryngeal intubation, and only a 51.6% success rate with endotracheal intubation. And I'm not saying this by any means to say anything bad about EMS or medics. I think it would be difficult to place an airway in some of the circumstances they're faced with, and that's what this study actually showed. So some other findings in the study: bystander CPR, you could see was done in about 55% of patients. And if you look at the column on the left, these are the laryngeal tube placements. The column on the right are endotracheal tube placements. And you can see about a 55% bystander CPR rate, which is it's a bit higher than the national average. Other things, I wanted to show you guys, compliance with assigned airway intervention was higher in the laryngeal group, lower in the endotracheal. And I think the thing with this, the way to read this, they had high success rates, so they stuck with laryngeal, right? But with endotracheal, they had, their success rates were about 50%. So they may have had to try a different airway. Transported to the hospital, so about 60% of patients were transported to the hospital, which is pretty darn good. About half of them got therapeutic hypothermia, which is kind of a scary thing to me, because I'm like, why aren't all of them getting therapeutic hypothermia? But other things to assess. Now this is kind of, this is where this really hits home. So remember, the left column is laryngeal, the right column is endotracheal. So initial, so when they look at out of hospital adverse events, multiple, defined as 3 or more insertion attempts, was statistically higher in the endotracheal group. Unsuccessful insertions were much higher in the endotracheal group. Unrecognized airway placement or airway dislodgement, again, statistically significant higher in the endotracheal group. And inadequate ventilation, though, was higher, statistically higher in the laryngeal group. So I don't think any of that is shocking to any of us, but just because endotracheal tube placement is so difficult. So let's look at the primary outcome, which was survival to 72 hours in laryngeal versus endotracheal intubation. And you can see the survival was statistically higher, so the p-value is less than 0.05, statistically higher in the laryngeal group. And then other secondary outcomes, the survival to hospital discharge was higher in the laryngeal group. It reached statistical significance. And then finally, neuro outcomes were higher in the laryngeal group, all reached statistical significance. So, you know, there were some major differences in this study between laryngeal and endotracheal tube placement. And this was a quote from Modia, is that our research revealed that sudden cardiac arrest patients who received newer and easier to use laryngeal tube as the initial airway had higher survival than those who were randomized to traditional endotracheal tube. And based on these results, they estimate that EMS providers could save an additional 10,000 lives per year if they switch to laryngeal tube over endotracheal tube intubation. And you know, it's interesting because of course this has a lot of the EMS groups up in arms and saying, you know, but we do it better, and you know, and that's fine. Like if you can show that you've got great success rates with endotracheal tube intubation, then I wouldn't switch. I would keep doing what you're doing. But if you're tracking and you are not having good success rates, really, I think the discussion needs to happen. Maybe it's time to switch back to or switch to laryngeal tube placement for resuscitation. So, you know, there were limitations to the study. I think one of the biggest limitations was CPR quality and ventilations weren't measured, which that's unfortunate. I mean, these studies are so expensive and so difficult to do, but I think that would have really add some robustness to the study. But other thing is there was no additional training for airway placements. So people were evaluated under existing protocols, which I actually think is a good thing, that we're basically saying, what do you do now and what are the outcomes showing? But the thing is, these results may not apply in the hospital setting. But and I'll kind of show you what was done in the hospital. So the question is, should we put an emphasis on advanced airway placement in the first 15 minutes? Now, this was a hospital study. Now, I've shown this in other webinars, but I want to revisit this. But this was an American Heart Association Get With the Guidelines database where they basically, it was a time-dependent propensity trial where they compared advanced airway placement in the first 15 minutes in patients, and then they compared that patient with one that they controlled and compared it with a patient that looked almost identical in the type of arrest, when the patient was intubated during the cardiac arrest, etc. And what they found, so this is a forest plot I'm about to show you guys, but what they found, so they looked at, you can see here, like shockable rhythms, non-shockable rhythms, what minute during the code the patient had an advanced airway placed, the type of illness the patient had, like medical cardiac, medical non-cardiac, were they a cardiac arrest, where was the patient in the hospital. So they basically looked at every different type of scenario, asking the question, should we place an endotracheal tube in the first 15 minutes in a cardiac arrest? And what you're going to see are confidence intervals pop up, which I call dots and whiskers, and if the dots and whiskers cross this line, that means it's not statistically significant. If they fall to the left of the line, that means it favors no intubation. If it falls to the right of the line, that favors intubation. And what they found was that overall, it did not favor intubation. So why? Why is that? And I think a number of reasons. I think all the reasons I've just talked about. We're ventilating too fast, we're using too much volume, we're administering positive pressure ventilation in people who normally negative pressure ventilate. That's our normal way to ventilate. But I think the other major issue is what I'm about to show you. Here, actually, let me just show you guys. This is a real code I'm about to show you guys. And you can see the patient's in VFib arrest, few pauses, but they at minute, was at 13, they took a 2-minute 42-second pause to do what? To intubate. So do we need to really make sure we are minimizing pauses around intubation? And the answer is yes. I mean, this is crazy, 2-minute 42-second pause for an intubation event. So how many of you out there have ever been asked, stop compression so we can place an airway? I can guarantee most of you on the other side of this webinar have probably been in that scenario. And so, that is something we've got to clean up. And I'll just tell you, a lot of agencies and hospitals have just gone to either BVM, so bag valve mask, with a ventilation bag, or laryngeal airway placement. And then if the patient gets resuscitated at that point under controlled circumstances, they'll place an advanced airway. So, I really think we need to question some of what we're doing just clinically, because this is absolutely detrimental. And so this was a super interesting study done by Graham Nickel out of the Resuscitation Outcome Consortium, or the ROC study group. So this was an out-of-hospital cardiac arrest study where they evaluated survival to discharge. And what they did was they compared, now remember, you don't have an advanced airway. So they compared continuous 2 minutes of compressions without pauses to give ventilation. So they would just asynchronously bag valve mask these patients, or they would do the traditional 30-2 and they would pause for breathing. And so those are the two different options, and they enrolled over 23,000 patients in 8 regions across the US and Canada. So Tracy, we're going to launch a poll. And so what I want to know from you guys, so again, here's the scenario. These patients don't have advanced airways. So they don't have an advanced airway, and they compared either going 30-2 to 2 minutes continuous. And I want to know what you guys think. So what do you guys think the study showed? So Tracy's launching a poll here. So what do you think the study showed? Was 30-2 better? Was 2 minutes continuous compressions better with asynchronous ventilations? Or were the outcomes the same? There were no statistical difference. All right, Tracy, so the poll is officially launched, right?
It is, Nicole.
Okay, cool. So let's see what everyone says. I'm excited to see what people say. What do you guys think the study showed? 30-2, so 30 compressions, two ventilations, so you take a pause in compressions, or doing 2 minutes continuous compressions with asynchronous ventilations, or were the outcomes the same? What do you think? Are the votes rolling in, Tracy?
They are. Let's just give everyone a few more seconds and then I'll share
Okay.
the results.
All right, I'm excited to see what you guys say for this one. Oh, okay. So a lot of you thought the 2 minutes continuous. 19% thought it was 30 to 2, and then 15% of you thought that the outcomes were the same. So the answer was the outcomes were the same. So there was no statistical difference. So Tracy, we'll go to the next slide. So basically what they found when they compared 30 to 2 minutes continuous is the outcomes were the same. So what this says to me is this says to me that, you know what, this might be an option for us if we're having major issues with pauses. Maybe it's an option for us to just use a bag valve mask or a laryngeal airway until we get the patient resuscitated. So this is basically looking at so this is one of the graphs from the study. And this is looking at the continuous chest compression arm. And what this is evaluating is the chest compression fraction. So what percentage of time did you spend on the chest giving compressions while the patient was pulseless? So this is the continuous chest compression. This is the 30 to 2. And what you can tell by this graph is that they were on the chest a heck of a lot more when they did continuous chest compressions versus the 30 to 2. So that's an advantage. That's a major advantage. And then what you can see, so this is a forest plot turned on its side. So I just showed you a forest plot in another graph, but basically this is the reference line. So remember, if anything crosses the reference line, it does not favor, or it's not statistically significant. And so what this says to me is like, you know what, it's not harmful if we do continuous chest compressions. So I don't know, I think this gives us another option. Now this was published in 2015 and AHA didn't make any changes in their recommendations, but it's just, I think it's good to know in a very large robust study that there was not harm caused from doing so there was no harm caused from doing continuous chest compressions, to keep us on the chest and minimize a lot of those pauses. So pretty cool stuff. All right, so our next question, this is what I want to know from all of you out there, is what is the most definitive method of confirming airway placement? So Tracy's going to launch a poll. And then I want you all to vote. So what is the most definitive method to confirm airway placement? Is it auscultation, so listening to lung sounds? Is it looking for chest expansion or chest rise? Is it using those CO2 colorimeter CO2 detectors where it changes orange and yellow? Is it waveform capnography or is it a chest x-ray? So what is the most definitive method of confirming airway placement to say this tube is in the lungs and not the gut? So which one is it? All right, Tracy, are the votes rolling in?
They are, Nicole.
Okay, so let's see what you guys say. Okay. Oh, yeah, so 39% of you said capnography. 19% of you said the CO2 detector. Now, I'm not going to say that the CO2 detector is wrong, but what I am going to say is that the continuous waveform capnography will get it right every single time. So there is a margin of error in those CO2 detector colorimeter devices. So auscultation is absolutely not the way. I know we do it. You cannot tell if the tube's in the lung versus the gut unless the gut's blowing up, like because there's so much air in it. You cannot tell by auscultating. It is waveform capnography is the answer there. And chest x-ray is needed, but chest x-ray doesn't tell you lungs versus gut. It tells you how high or how low that endotracheal tube is. So, all right, so nice job everyone on that. So we'll get back to the last portion of the presentation here. And so just to kind of wrap things up in this presentation, capnography is going to be the most definitive method to confirm airway placement. So I think one of the major advantages of capnography, so you can kind of see here on this defibrillator, is that it tells you how fast you're ventilating the patient. So that's one major, I think, plus on capnography. I mean, there's other pluses as well, but this talk is specifically about airway and breathing. And when you use capnography, you've now got a visual to tell you how fast you're ventilating that patient. So, but it'll tell you as well if your tube is dislodged. It will tell you immediately if you've got an endotracheal tube that is dislodged. But so the devices, again, will display the ventilation rate that's being provided to patients during cardiac arrest, as well as the capnography value. And you can see this is just another device showing that you can see what the patient's ventilation rate is during cardiac arrest. So I think major pluses there. And then finally, just the last thing to mention is that you will know right away if your airway has been displaced. What you'll see is a flat line. And so even in cardiac arrest, you should get some sort of a waveform on your capnography. But if that tube has been displaced, then what like into the hypopharynx is the area that it gets displaced most often, you'll get a flat line. So you will know right away if the tube's been displaced. And I love this. So the UK did this big push for capnography. After a couple years ago, they lost a couple of patients from it was basically from esophageal airway placement, and capnography was not used in either of the cases. And their little motto that they started was "no trace, wrong place," meaning if you don't have a capnography waveform, you'll get something even in cardiac arrest. But if you don't have a capnography waveform, that tube is in the wrong place. So no trace, wrong place, and patients can die from inaccurate. From incorrect tube placement. So this is not a little deal. This is actually a really big deal for patients. So I think just some take home points is stay on the chest, minimize pauses when airways are being placed. Do not overventilate. So this can mean breathing too fast or giving too much volume to patients. It has major physiologic effects. Overventilation, again, is very harmful in patients. Capnography can be extremely helpful during resuscitations. And then kind of going back to overventilation, I don't know if you guys have seen on the market, but there's a couple of different companies that make ventilation bags that you set the volume that you want to ventilate the patient. So you can say like 400 cc's, 500 cc's, and it literally will not let you give too much volume. And so there's a couple of different companies that make ventilation bags that limit the air. Capnography is extremely helpful during resuscitation, and just promise me you will not overventilate. It's one breath every 6 seconds or 30 to 2 if you don't have an airway. So this is my contact information. So if you have any questions, we're actually going to take questions now. So load your questions. And but I host a podcast show for Stryker, who sponsored this. It's called Resus 10. And there's a physician named Brian Clemency who's out of New York, and he and we're going to have an episode launching, I think, in the next month, where we talk about these airway trials that were done in the pre-hospital segment and what it means clinically. And I think one of the tough things in a lot of the research that's done in resuscitation, one of the really tough things is that most of the research is done in the pre-hospital segment, and we have to decide, if we work in hospital, how do the results from these studies apply to us, and how is our work environment different? And so you've got to really be careful when you're evaluating research that's done in resuscitation to ask, where was it done and how might that be different to my work area? So all right, so with that, I'm going to hand it back over to Kim Kelly, who's the moderator, and she's going to give you some information on CEs, and then she's going to take some questions.
Thank you, Nicole. That was super thought-provoking. That was a great presentation. So before we get into any questions, I do want to kind of refresh your guys' memories into talking about the CEs. This activity has been approved for 1 contact hour. If you go to saxtesting.com/SL, you'll need to register on the test site and complete the evaluation form. And then upon successful submission, you'll be able to print that certificate of completion. The support for this educational activity has been provided by Stryker. So we will get into some questions here at this point. Just a few, some really good ones. Cynthia asked, what happens physically when the oxygen level is high? Why is the death rate higher?
Oh, that's an awesome question. Yeah, so there's a few things. We think a couple things. So first of all, so oxygen in the lungs acts as a vasodilator. Oxygen in the periphery actually acts as a vasoconstrictor. So that's one hypothetical reason. The other hypothetical reasons are that when we blast patients with oxygen, that often can lead to oxygen-free radical production and oxidative stress, which worsens injury. And so those are the two main physiologic reasons that people think hyperoxemia can be so detrimental to patients. So we think it causes mitochondrial injury at the cellular level and just really lends to oxidative stress. And the IOTA trial is fascinating. And if anybody wants that paper, pop me an email and I'll send you that paper. That IOTA trial was absolutely fascinating. It was a big meta-analysis of 25 different studies. I mean, looking at you guys, they were evaluating basics. So we're talking basic oxygen. This could be like via cannula, via just any supplemental oxygen running a sat above 96% or above. Think about that. The mortality was higher when we run liberal SpO2s on patients. And again, if anybody wants that paper, just pop me an email. So it's the nkupchik@gmail.com. And I will, I'm actually in my office all day today, so I'll get that paper out to you guys. I thought that paper was eye-opening.
That does sound really interesting. I want that paper, Nicole.
Okay, I'll send it to you.
Thank you.
Yeah, no
The
problem.
next question is from Felicia. Where did the rate of 10 breaths per minute come from? Was this studied?
Yeah, that's one of the areas we know is lacking is we don't know what the optimal rate is. I think the rate came, I'm not positive. I think the rate came from because being that that's a normal ventilation rate. Now, I will tell you there were animal studies published demonstrating when you increase the rate, so when the rate is increased, it leads to decreased coronary perfusion pressure and decreased cerebral perfusion pressure. So, but again, that's all animal data. This would be really, really difficult to study in humans, if not impossible. But that's the best answer I can give you.
That makes sense. I have kind of the same question from two different people.
Okay.
John and Pepsi both asked kind of the similar question. John said, I had a doctor demand that I hyperventilate during arrest with an ET
Oh,
tube because he
yeah.
knows we will have a metabolic acidosis that requires compensation. He said ACLS guidelines for ventilation are inadequate. As an addendum, he qualified his statement by saying in some circumstances that ventilation guidelines are adequate. So Pepsi was also kind of asking that same situation of, well, how do you handle when a physician asks you to bag faster or cause overventilation?
Oh gosh, yeah. I mean, it's tough to have this conversation like right in the heat of a code, right? But here's the physiologic answer to this: is if you like, because I've done I do an ABG course where I give an example of that, where you've got a patient who's in a cardiac arrest, and the case I had, I think the patient's PaCO2 was like 87, and the request was made to bag faster during cardiac arrest to blow off the CO2. Okay, so here's the deal: you're going to have acidosis in a code. The patient's dead, okay? I mean, like, I don't mean to sound so blunt, but they're going to be acidotic. So is the right thing to bag faster? The answer is no, absolutely not. Now if an acidosis caused the code, even then, if they're getting chest compressions, by increasing your ventilation rate, that's going to have a major negative impact on CPR quality. Again, why? Because you're increasing the intrathoracic chest pressure, which decreases venous return. And there is data, again, it's a lot of it's animal data, but definitely demonstrating the higher the intrathoracic chest pressure, the lower the coronary perfusion pressure. And so what I always say is, now is not the time to fix the CO2. We'll fix it post arrest. I mean, it's very easy post arrest to fix the CO2 to make our numbers look pretty. But intra arrest is not the time to do it. And I don't know, like, I think at this point, what I would do is if you work with that person is I would just go have and make an appointment, go sit with them and say, hey, in a code that we were in, you made this request. I just have some major concerns about this request, and bring the physiologic evidence of why you have a concern. I just, intra-arrest, it's really tough to have that conversation. I'll be honest, have sometimes has the request been made and we're like, oh yeah, okay, we'll do it, and then we don't do it, sure. But the conversation needs to happen in a calm environment, really querying where they're getting this information from.
Yeah, I've never actually, in my experience, have never had a physician tell us to bag faster.
Yeah, I
So
have.
that's a really, have you?
Yes, I
I
absolutely have. Yeah.
That's an interesting concept. Uh, I think Nicole's recommendations are really, really good, kind of just not in the heat of the moment. Amber has another question that's kind of very similar along that same theme. She's a respiratory therapist, and at her hospital, physicians stop CPR quite frequently to intubate, despite telling them to wait. Do you recommend any ways to educate physicians against stopping compressions? Kind of
Well,
along the same thread.
yeah, I mean, I have to say, um, okay, so I know one of the things we had done is we'd have somebody like when they're coming off chest. So when the request is made to come off chest, we'll actually have a timer. And we will say, okay, it's 10 seconds. We got to get back on the chest. Um, in that case I showed you guys, I'm sure that the physician who intubated did not think that they were off the chest 2 minutes and 42 seconds. It's super clear. If we're not intubating, the patient's I'm sorry, if we're not doing compressions, the patient's not getting perfused. And the data are really clear. We need circulation, to have better outcomes in cardiac arrest. So, I think one of the strategies you could use is literally when they say stop compressions for airway placement, is just start your stopwatch and time it. And the other thing is, I know what we'll do is like some of our anesthesiologists would be like ready to go with all of their supplies, be totally ready to go, like tube entered the mouth, and then when they stop compressions, that's the point at which they'll try to get the tube placed. But I mean, really, if you have an open airway and you're ventilating just fine, really what needs to happen is a discussion on, do we really need to intubate this patient? And I think discussions like this need to happen in a calm environment, not in the middle of an arrest, but really like at your code blue committees or with leaders that are running your codes. These discussions need to happen. And I just think facilities need to have a stance of compressions are paramount. We need to minimize interruptions and compressions. And you just have to stick to it and kind of create an environment that really supports that, where people stay on the chest.
I agree. I agree. Don't ever do it in a immediate situation just because it's not going to stick as well as a dedicated conversation away from the stress, away from the chaos.
Yeah, but I
So,
think, yeah, but I would say, like, let's say today you're, or tonight or tomorrow you're in a code. Again, the strategy of starting a stopwatch. Everybody's got a phone. It's usually in your pocket. Get out that phone and say, okay, we're already 15 seconds off. We need to get back on this chest. Because again, if the patient's not getting compressions, they're not getting perfused.
precisely. Jennifer has a question. Is the American Heart Association recognizing the data presented, and do you think we'll be seeing changes in the AHA algorithms?
You know, so the AHA has changed the way they do the guidelines. So what they're doing is, so 2015 we had a big guideline overhaul, and then every year in November, so every November is the big American Heart Association conference, and at that conference they'll release updates to the guidelines. I haven't seen any major overhauls yet to specifically to this topic. Do they look at the data? Yes, I will tell you, they've got a dedicated teams that look at every aspect of resuscitation and evaluate the data. So the way it goes is to get something off the guidelines. So let's look at the guidelines the way they're printed today, right? To get something out of the guidelines, you need a study that shows that it's either not beneficial or it's harmful. And so you've got to have strong data to get something out of the guidelines. So, and I know the HA and the International Liaison Committee on Resuscitation is always evaluating new data. So that's the long-winded answer to that.
Perfect. I think we're just going to take one more question at this point. There have been really, really great questions, but the one last one I'm going to ask or get to is Eugene's, or no, I'm sorry, it was Kathleen's. Is the LMA considered an advanced airway?
It's considered a laryngeal airway. So, like in the true sense of the form, it's not an endotracheal tube. So, an endotracheal tube would be your classic advanced airway. So, we classify it in its own category of laryngeal airways or subglottic airways.
Thank you. That was great. Thank you very much.
Yes.
I hand this back to Tracy for just a few more instructions.
Thank you, Nicole and Kim, for such a great presentation today. And we'd also like to thank everyone for attending today's webinar. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open. For those that participated in a group, please let us know how many were in your group, and we appreciate your feedback. In 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits, and that's saxtexting.com/SL. And on behalf of Saks Healthcare Communications and our presenters today, thanks for joining us and have a great rest of your day.